Hi, everyone. I've got two experts in my office today, Molly McCoy and Linda McCain. They are with McCoy McCain Advisors. And clients this time of year are thinking about Medicare. Yes. We're just entering open enrollment, correct? Molly, if you could kind of start and just kind of share with us, what are some of the biggest mistakes that clients make when they're enrolling?
Yeah, absolutely, Tommy. One of the biggest mistakes people do is actually missing that initial enrollment period. So that's something to be very cognizant of. Another mistake people make is maybe choosing a plan based on what their neighbor has or what a friend has or, what a family member has said was great for them. No two people have the same medical and financial concerns, and no two plans are the same. So it really is necessary to make sure you're finding a plan that's best for you. Another mistake is assuming that original Medicare covers everything. It doesn't. There are a lot of gaps in coverage that we'll get into later. It's important to know what those gaps are and what you potentially maybe need to do to supplement that. And then finally, not renewing plans on an annual basis. You may feel like, okay, I've gotten into Medicare, I picked my plan, I'm ready to go and for the rest of my life. But your medical needs are not static, they change and the plans change. So it's really important that you're reviewing those on an annual basis with an expert that can help consult based on your needs.
Sure. And can you tell us, what is the window of enrollment?
Absolutely. That initial enrollment period window is a 7-month window surrounding the month you turn 65. So it begins 3 months before you turn 65 and it ends 3 months after that month you turn 65. And there's some penalties associated if you do miss that initial enrollment period window. Those penalties apply to your Part B premiums through Original Medicare. They may tack on an additional 10% for every 12 months that you miss that window. And your Part D, which is your prescription drug coverage, could be increased by 1% of the national base rate every month you miss that window. And of course, there's that big gap in coverage because you would have a potential of exposure that you financially aren't prepared to take care of.
Medicare is often described as not being free. Can you kind of explain on what comes with the cost?
I'm glad you asked that question, Tommy, because people are surprised. Many people think that Medicare is free and don't recognize that there are costs associated. There's premiums that can come into play. There's out-of-pocket costs as people use their coverage.
How do they vary across the different parts, like A, B, C, and D?
Good question. So A and B make up Original Medicare. A, generally speaking, is your hospital care. So that is care when you go inpatient hospital, skilled nursing, that falls under Medicare Part A. If you or your spouse have worked in the country for 40 quarters or 10, it equates to 10 years, your Medicare Part A, you've paid into that while you were working. So there is no premium. You've paid it. It's premium free. And for many, that's what that looks like for Part A. If you have not met that criteria, then there will be a premium for Part A. And Social Security will let you know what that is when you go to sign up. Part B is the other half of Original Medicare, and it does have a premium. And it's very important to be aware of that. It's income-based in that what I pay, what you pay may look a little bit different. There's a standard premium and there's thresholds set by Social Security, dependent upon where your income falls, will determine what your Part B premium amount is. There's a few things to consider with Original Medicare. First, too, is that Original Medicare does not include prescription drug coverage. So in order to pick up prescription drug coverage, you purchase that from a private insurance company. And there's a premium associated with the Part D plan that you choose. And you could purchase that as a standalone, or you could purchase a Medicare Advantage plan, which has prescription drugs built in. So you can get it in a couple of different ways, but there's a premium tied to Part D. Also out-of-pocket costs. So depending upon, and it's sold by private insurance companies is where you pick up a Part D. So you might have deductibles on your plan, co-pays, co-insurance, dependent upon the carrier you're with, the medications that you're taking. The good thing with Part D, unlike Original Medicare Part A and B, is that there is an out-of-pocket maximum.
Okay.
So if you have a significant spend in your drugs in a given year,
Mhm.
there is a stopgap. The universal number, it's a threshold for
Mhm.
2025. The threshold is for 2025. The threshold is 2,000.
Okay.
2026, that is going up to 2,100
Okay.
by way of a Medicare supplement.
Mhm.
Those plans are designed to sit alongside original Medicare
Okay.
and pick up the costs, most of the costs that original Medicare leaves on the table.
Okay. Yeah. So you talked a little bit about original Medicare,
Mhm.
and then Medicare Advantage is the supplement.
Yeah,
Can you kind of expand on
yeah,
that,
I
Molly?
can take that. So Linda did a great job of explaining all those gaps that are out there,
Yeah.
and it can make it feel a little overwhelming, but we can really break it down to a system choice. You have a system choice between original Medicare, which then means the Medicare, the government is your health insurance provider.
Mm.
They take in the claim. You can go to any physician across the country that accepts Medicare. They receive the claim. And then all those gaps that Linda described that are there if you're in the hospital or anywhere else, the deductibles, copays, and coinsurances, those then get filed with a Medicare supplement carrier that you've purchased a policy through. And they pick up the majority of that. They may
Okay.
have small deductibles or copays in there,
Mhm.
but the majority of that out-of-pocket exposure that you have with original Medicare is picked up by those Medicare supplement choice you have is to say, I'm enrolling in part A and B. I've got my beautiful red, white, and blue card. I'm going to tuck it into my wallet, keep it somewhere safe.
Mhm.
And then I'm instead going to choose purchasing a Medicare Advantage prescription drug plan through a private insurance company.
Mhm.
They then take over the responsibility of managing your healthcare costs and claims from the government. So then what happens is the government, Medicare, pays that private insurance company to take on your responsibility, and they manage it. The claims then go into that private carrier, and they adjudicate them based on, the formulary and what's considered, a covered service. The difference there is that you are required to go within a network of physicians. Now, we're really fortunate in Michigan. The private insurance companies with MAPD plans have very broad networks. And so there's a really strong chance that the doctors that you're currently seeing are going to align with one of the many options that are out there. But they're able to do that in a way that provides you this coverage with little to sometimes no premium. You can purchase MAPD plans with zero premium charge to it. And then they have deductibles, copays, and coinsurances that you're able to financially prepare for and manage.
Mhm.
And they bring extras as well. We mentioned that they include that prescription drug coverage, so you don't have to purchase a separate
Mhm.
prescription drug plan. And they sometimes will provide you dental, vision, hearing, over-the-counter benefits, even fitness, gym memberships. So it's really kind of a system choice. I'm going to stick with original Medicare, add on a supplement and a drug card, and pay more premium, but have access anywhere I want to go
Sure.
that accepts Medicare nationally. Or I'm willing to work within a network of providers, and I have lower cost initially, very low premium that's required, sometimes none, and I get all those extra bells and whistles. And again, everybody's different. So
Yeah.
the choice is really going to be tailored to what your lifestyle is, who the doctors are you go to, and the drugs that you're taking.
You mentioned.
I often recommend to people who are traveling that they purchase a travel assistance program.
Okay.
Some of the Medicare Advantage plans have travel assistance as part of the plan as an extra benefit. So as Molly mentioned, outside of the walls of the US,
Mhm.
emergency and urgent, you may pay out of pocket,
Mhm.
but know that some of these plans do have built-in assistance. So if you're out of the country and you're having a situation, you get a number on the back of your card, you can call translators, people to help you navigate the care.
I just think about Medicare alongside like long-term care planning.
Another very good question.
Yeah.
The short answer, separate.
Yes.
Separate. And that's confusing as well for many people. You think Medicare, some people, myself included at first, thought includes long-term care.
Mhm.
Well, it does not, Tommy.
Mhm.
When you think Medicare, think health coverage,
Okay.
hospitalization, doctor's office visits, skilled nursing, other medical
Okay.
procedures, separate bucket.
Mhm.
Long-term care, that's someone who needs help with daily activities,
Mhm.
dressing, bathing, custodial care, perhaps they're in a nursing home,
Sure.
long-term care. Two different strategies as you are.
Sometimes when we're sitting down with a client, we'll look at all of the what if scenarios.
Mhm.
So when we're doing retirement planning, we're not just looking at like what do you need on a monthly basis as far as retirement income. But we're looking at if it's a spouse, two spouses. It's like, well, what if one of you has a long-term care need when you're 85?
Right.
Is that going to deplete the other one's assets?
Right.
And so that is part of the planning process. But it's
Mhm.
nice to know and to just clarify that Medicare is hospital and, doctor visits. Long-term care is completely separate and should be planned for separately.
That's correct.
For clients who continue to work past 65, that's, the 65 is the new 45.
Right.
Right. So there's a lot of people that are working still, and we have a lot of clients that are self-employed and they just love what they do, and
Sure.
they're working past 65, and some of them are even working past 70.
Sure.
And so what does that look like in terms of Medicare? Because I know
Yeah.
the initial enrollment is around age 65.
Correct.
Can you kind of talk on that?
Yeah, I can take that one for you, Tommy. First thing you have to do, if you're still working past 65, is determine what type of employer you're working for.
Okay.
If you're working for a small group employer, which is any employer that has less than 20 employees, Medicare is primary. So even if you're enrolled on their group health insurance plan that they offer their employees, you still have to enroll in Part A and B on time in that 7-month window, because that is going to pay primary, and the insurance company through your employer's group plan is going to pay secondary. So at that point, some people might decide to disenroll from their employer group plan and enroll in a supplement or an MAPD plan and just completely go the Medicare route. Again, it's kind of, you need to get that consultation to look at the financial equation that's involved in there. What's the difference in premium being on the group plan versus going with, a Medicare plan? But you can't delay your enrollment if you work for a small group employer.
Small group, again, just reiterates 20,
under 20,
20 and
under
under.
20,
Okay.
under 20, 19.
Under 20.
Yes.
Okay, got it.
But if you work for a large employer, which is 20 or greater, then that group health insurance plan that's offered through your employer is primary and Medicare is secondary.
Okay.
So because of that, you can delay enrollment because you don't want to have to pay your Part B premiums if you already have credible coverage through your group health insurance with your employer. So that delay can take place as long as you have that credible coverage in place, and it includes a prescription drug card plan. You can delay that until the point where you decide, okay, now I am ready to retire and I'm no longer going to be, have this group health insurance available to me. That opens up what's called a special enrollment period. So you then get a new window for when you're free of any of those penalties to the premiums or any of considerations of having a delay in coverage.
Seeing some changes in the original Medicare space that have never been seen before. There is in 2026, there's going to be some changes as it relates to prior authorizations, and that's in the news spotlight right now. Prior authorizations are in play in commercial insurance. They're a cost control measure. They are really target fraud. They've got a big spotlight on fraud, and you would be amazed at how much fraud there actually is out in the system. So for the first time starting in 2026, Medicare is CMS is doing a pilot program. There's 6 states involved. They looked at 17 procedures that are vulnerable for fraud, and they expect that putting in prior authorizations, which are not to limit somebody from getting care. I think that's really important because there's a lot of question on, well, what does this mean? Are they going to limit me from getting care? No, that's not the intent of prior authorization. It's to look at that fraud piece, and that will save billions to the system. So that's right. Like prescription drug reform. There is, and that was part of the Inflation Act in 2022, where, and this is something that's been happening in the commercial space and commercial insurance space for a long time, where there is negotiating for prescription drug pricing. There are so many fantastic prescription medications on the market that help people, live healthy lives and extend lives. Some of those come with a really high price tag. And having the ability to negotiate pricing with the drug manufacturers, that's a cost savings tool.
Mhm.
And original Medicare has not been, it's not been a space that they've been active in.
Sure.
And so that's a new initiative. There are a limited number of medications in this upcoming year that are going to be subject to pricing, negotiated pricing measures.
Mhm.
That list is expected to grow,
Mhm.
and that'll be good for the members because it's going to lower their cost share.
Mhm.
It's-
It's the financial planning process. When we sit down with clients, we're talking about retirement, and we do it ongoing because their plan changes as their income changes, their
Mhm.
needs like healthcare changes. And one of the things that we do when we sit down and strategize, especially around a lot of retirees have a lot of money in their 401k, which is usually now a traditional IRA.
Mhm.
And the big buzzword in our industry is, should you do a Roth conversion? Should you convert it from a traditional to a Roth and pay the taxes in the year that you convert it? But inadvertently, sometimes what happens is that their Medicare Part B premiums go up in the
Mhm.
following year or two because now their income is higher than what it had been.
Right.
And so I think it's really important, just as what you do for your clients, is to sit down and look at all of the what if scenarios, like take a holistic view of what do they need from Medicare or the original Medicare or Medicare Advantage, and then how can they strategize to make sure that they understand all of the maybe unintended consequences of what's their out-of-pocket expense going to be and things like that.
Right.
So
Mhm.
Medicare is, like you said, it's confusing and sometimes it's a little overwhelming, especially when you're new to it.
Right.
And so I love that you two come in with a lot of passion and knowledge around this.
Yeah, thank you, Tom.
Thank you.
Between Linda and I, we have 60
Yeah.
years of experience in the insurance industry.
Process for you if like one of our clients were to
Sure.
reach out to you. What does that
Yeah,
look like?
if they were to send their contact information over, we would send them a needs assessment.
Okay.
That is like an intake form that helps us understand, the drugs they're taking, the doctors they're seeing, a little bit more about, their location, geographically. That makes a difference too on what types of plans to recommend. And then they would sign a form that's a scope of appointment that basically gives us permission to start working with them. And then we would have a conversation, a discovery call to delve in deeper into that before even making any recommendations.
Okay, like that.
Mhm.
Excellent. Can you tell us one more time how they reach out to you?
They go to McCoymcCain.com and click contact us and send us a note and we'll get a hold of them right away.
Of the activity going on in the prescription drug space,
Mhm.
and that's new to Medicare too.
Mhm.
You just drop an earring.
We need to reshoot that question.